2, 1. And we are back live at the Digital Orthopedic Conference's COVID-19 Orthopaedic Response, brought to you in partnership with the Department of Orthopedic Surgery at UCSF. And very importantly, we're joined by the American Academy of Orthopedic Surgery in promoting, discussing these topics, which are so relative to our community as we try to tackle and manage and respond to COVID-19. I'm now joined by Todd Johnson. He is a chief, oh gosh, Todd, I already forgot, you told me.
Strategy officer.
I was going to say that, but wasn't sure. Chief strategy officer. He used to be the CEO of Health Loop that was acquired by, who you guys acquired by?
The GetWell Network.
The GetWell Network. So now you're now at GetWell Network, and he's going to tell us about the patient engagement platform he developed and been working on now for I think 7 years. Todd?
Yeah, it's been a while.
So, and we've had the pleasure of working with you, and can't wait to hear more about it and how we can use technologies like this to manage orthopedic patients. I will get out of your way and let you take the screen.
Thank you, Stefano, and thank you to the Academy, and thank you everybody for who's attending. This will be a relatively brief overview of both capabilities that we're seeing health systems adopt to attack sort of the crisis in front of us, and some historical reflection on how those have fit within orthopedic practice. And then we'll talk just momentarily about the relaxation of some of the regulatory rules in the United States that I think makes this even more urgent and relevant today. The GetWell Network is based out of Washington, D.C. or Bethesda, Maryland. We serve about 700 hospitals and medical groups here domestically in the United States, in Australia, in the Middle East, and the UK. Our business is really designed around patient experience and patient engagement to empower patients and their family members to get the best outcomes we can using digital tools. And as all of you are going through, we are, as a technology company, seeing an enormous amount of activity and speed to try to figure out how to scale technology capabilities to triage and engage with patients as they are suspected or become tested positive. And so what we're hearing from our health systems around the country here is that we don't have enough tests. How do we communicate with patients that we can and can't test today? How do we keep our community members up to date with the latest, most reliable information? How can we support our employees who are now getting sick and at home? And how do we just staff an entirely new model where we can't really have patients in the clinic? And we've got to rethink our delivery system as a whole. Taking a step back, what I'm observing and what we're observing from health systems at a systemic level, and we'll talk about sort of the individual medical group momentarily, is they're rapidly moving to bring online 3 different sort of capabilities. First is self-service tools for individuals in the community that may be fearful that they have the coronavirus, and are interested in getting tested. And so you're seeing a huge surge of kind of symptom checkers whose main responsibility is to sort of separate those who need to get tested and those that need support. The next category, and this is where our company really spikes with the Loop product, is then patients who are in self-quarantine, patients who have tested positive, or even patients that have been in the acute care setting and are recovering at home. How do we provide daily management of them to empower them with the right education to self-manage, carefully monitor their symptoms using remote patient monitoring to identify who may need additional support or be triaged into the acute care setting, secure messaging between individuals and the clinical teams, and really as a mechanism to route patients to the right site of care, setting of care, or take care of those that don't need it in an automated way. And then the third category is, video visits, so that when a patient does need direct interaction from a provider, that can be done through video. Of note, these second 2 categories, remote patient monitoring, digital care management, and video visits, are all being reimbursed both by the Center for Medicare and Medicaid Services, the largest payer here in the United States, as well as by commercial payers. We're seeing a tremendous amount of relaxation around some rules here, as well as waiving patient copays. So for a practice that moves to engage digitally with patients, there's some, at least some revenue attached to this that I think is going to help to create the incentives. So specifically drilling into these digital care management and remote patient monitoring programs. Ironically, we've been working in the orthopedic space for years, and orthopedics, through both bundled payment programs and other quality improvement programs, offered a sort of a ground zero for testing capabilities to put in automation to carefully guide patients through an episode of care, what to expect before, during, and after a surgical episode, both in terms of patients, what they can do to optimize for coming in, and then carefully monitoring their recovery, but letting technology be this first point of interaction where the technology can push out to the patient on a daily basis with the right information at the right time. But the technology then separates which patients actually need follow-up. So if you knew a patient, 4 days after being discharged from the hospital was developing signs and symptoms of a blood clot or an infection, you would want to escalate them quickly. And so it creates a first tier for care management to separate patients that are doing fine with those that need support and get them in right for triage. And so this typically works, most of our patients, and we've done millions of patients now, just launching our COVID-19 programs, which I'll share momentarily, with these longitudinal care plans, which are pre-programmed sequences of push notifications with education, information, resources, and tasks. And then on the back end, the ability to triage patients and separate those that are escalated. To respond to the COVID-19, we've already launched a number of programs to our health system partners and medical group partners, really aligned around today, before hospitalizations occur. We're also now releasing a number of programs to support patients that were discharged from the hospital and are recovering at home. But these are really designed to provide the latest information, and our clinical teams are revising these on a biweekly basis with the latest guidelines to provide supporting information to empower patients with accurate information. And most of the content is coming from the CDC or the WHO. And then monitoring their symptoms, so daily assessments around their temperature, their shortness of breath, and other clinical indications, right? So that we can monitor patients and understand their recoveries. And what's interesting is you can imagine pulling these data points where we're getting daily data points from patients across typically a 14 or an 18-day window, and looking at these patterns at scale to see what we can learn, potentially surfacing early warning signs of patients that may represent more elevated risk. And so for patients, what this feels like is my medical team reaching out to me with the right information at the right time. Really, one of the main goals of these programs is to reduce anxiety, right? Provide trusted information to separate, all the noise that we're seeing online with information that is highly targeted but vetted by clinical teams. Educating patients on how to self-monitor and self-manage those symptoms, right? Hopefully keeping as many patients as we can from having to come in and see clinicians. And then providing them with kind of the right resources, but carefully monitoring their symptoms so that we know who and when to escalate patients that may require greater intensity of services. And then for care management teams, this is really about serving huge populations simultaneously and scaling the impact of any individual and allowing technology to be at the front end. Really, the hopes is how can we serve our communities? And we're starting to do things that are surprising me. Whole states are looking at signing these programs up to take care of communities. And so we're starting to see a real explosion in the use of these platforms. But can we use and leverage the technology to reduce as much of the synchronous communication back and forth between the care teams and their patients, so that we can treat a greater number of patients simultaneously, and again, focus efforts on those that we need to. Also, for clinical teams, we do want to ensure that we're capturing the appropriate and necessary documentation to support reimbursement across these programs. I'll just say, Stefano had mentioned that we've been at this for 7 years. In 7 years, or maybe the first 6 years, we've been able to sign up maybe 70 hospitals and another 80 to 100 independent medical groups and specialty medical groups. In the last 2.5 weeks, we've signed up nearly 200 hospitals. We've got 8,000 patients now enrolled, and that's sort of at an exponential growth rate. So we're seeing huge participation rates from patients that are growing up and to the right. And the gating factor there is how are medical groups and health systems enrolling those patients. Patients are pretty thrilled with this. The patient satisfaction rates for this first initial cohort are very high. 16% cite a reduction in phone calls and visits. And we've figured out 5-day cycle times to get systems live. Now, there's a lot of stuff that goes into those speeds. I mean, typically, prior to COVID-19, our cycle times were 60 to 90 days. So sort of a huge improvement. Taking the lens, so a lot of the work that we've been doing in the last 2.5 weeks is really supporting health systems at a system level to serve their community of patients. When I drill down into kind of what this is going to mean for specialists and other providers that are having to cancel and defer acute care for now and are seeing a slowdown, one is we've deployed programs to our orthopedic partners that are designed to sort of keep in touch with patients as we seek to reschedule surgeries down the road. I do think if you look at what the Medicare waivers have done in the last week, it's sort of hard to keep up with the pace of everything. But now, televisits and phone-based visits should be paid on par with traditional E&M consults. Patient copays are being waived. Medicare is providing a 20% increase in reimbursements prior to what they've been paying. So there's kind of eliminating a bunch of the HIPAA and security requirements and just saying to doctors, do whatever you need to do to take care of your patients in the community with this new requirement that we want to serve patients in their homes as opposed to in the clinic or in the hospital as much as we possibly can. And so I would look to engage my entire panel of patients using remote patient monitoring and asynchronous communications to both keep a line open to them, to be a safety net and a reassurance to them as they are, dealing with medical issues that may not rise to the level of urgency or acuity to actually come into the hospital. But at least we can both stay connected to those patients, help them with continuity of care. We're seeing a lot of this in the oncology space. Where deferring and delaying treatment is really challenging. And at least patients can, or providers rather, can be reimbursed for these services. And then lastly, when patients do require face-to-face visits, certainly partnering with a telemedicine partner so that you can provide those over a video consult and also get paid for those. So that's sort of the conclusion of the prepared pieces here. I'm happy to answer anyone's questions. I think this has been such an incredibly fast-moving 2 weeks. I'll just say I'm still sort of drinking from the fire hose and haven't had a heck of a lot of time to synthesize all of my thoughts, but happy to share with you all. Exciting.
Thank you, Todd. That was a really good and very thorough assessment of your platform. And, it's the growth is one I want to talk about first. It looks like you have a tremendous amount of interest, and we were able to increase the number of patients on your platform very quickly. And to the point we made in our last session with Sean is that there's no real barrier to the patients, is there? They're more than happy to do this. It's not like there's a phobia around the technology on the patient side.
No, I think patients are very, very comfortable using these tools. They want to. I do think that where providers can really have a greater level of reassurance. Everyone's a little bit scared right now. And one of the reasons why we see such strong participation rates is that it's really a communication platform that's delivered on behalf of their provider, their surgeon, right? Their MD. And so it's that trust and familiarity that I think makes it even easier for patients to participate in this stuff.
So tell me about the age distribution, to stay on that note, of the patient population you're working with.
So for the coronavirus patients, Interestingly, with our first 8,000, and I may not have the exact numbers right in my head, but I looked at a data cut yesterday, and I want to say 80 to 85%, we sort of, in our analytics, are cutting them into juvenile, elderly, and then everybody else. So I don't know that this is exactly how the data is cut, but juvenile, let's just say it's 18 and below, and elderly is probably 80 and above or 85 and above. The vast majority of patients we're seeing are in that middle category, not the 85 and older, and not the juvenile. We're seeing similar participation rates across the boards. Traditionally, with surgical patients, we see the strongest participation rates happen to be in the 60 to 80-year-old. But like the 26-year-old that's having sports medicine doesn't value the digital connectivity to their doctor the same way maybe 70-year-old person that's in a lot of pain does. That's been traditional. With the coronavirus loops, we're seeing strong participation across every age segment. And we don't know exactly why, but we can guess. And I think it's worry and anxiety, right? There's a lot of fear going on.
So let's talk about the powers of being on a platform. You're collecting data, and you say on the back end, you might be able to gather some ideas or thoughts around that.
Yeah. At a minimum, just think like we'll have, self-reported rates, daily temperatures or often multiple times a day from, all of these patients who have been diagnosed positive with coronavirus, or daily self assessments around shortness of breath, right? So there's sort of these self-reported clinical data elements that, as we get enough scale, I think may provide something interesting. Then there's also behavioral habits. So like, do patients participate in the program? Where do they drop off? Do they not drop off? And then other attributes, like in the programs that we put together, there's a clinical tier, like here's what you need to know clinically, and then assessing your symptoms clinically. But then there's a lot of things that are around sort of the non-clinical support for patients, psychosocial support. We're with our next version of this program, we're introducing behavioral health components to try and detect anxiety and depression and provide support for those. So I think we'll probably begin to see patterns emerge that hopefully will give us clues as to who may be at higher risk. And of course, we're collecting comorbid conditions up front, so that's an easy thing to do. So maybe we'll learn something about who is indeed at a higher risk for clinical failure.
So let's go down that road. And it sounds like you're thinking that a patient engagement platform that outreaches to patients could be used as a triage tool.
Yeah, I mean, that's exactly what's happening, right? So all of this daily data that's being collected, we're looking at it both over time and then the snapshot of today. And depending on how the symptoms are surfacing, we're escalating that to I'll say the clinical team broadly, but there's a lot of different permutations of how organizations are structuring it. So some are having like an enterprise care management nursing call center that's triaging that. Others are distributing it to primary care, right? And then in the case of specialists that are managing their own panels of patients, it's typically the specialist team that are doing that triage.
So I have a couple of questions coming up. I want to take one from John Macy. He reads, what is the cost of this technology, and has there been any consideration of the current economic situation when pricing for institutions that may not have significant funding for this, like a typical community hospital?
Yeah. So for our coronavirus programs, we're essentially making them available to providers at no expense. We are charging for some of the implementation times to get them up and running. But I think the commercial strategy on this is we need this right now. Let's not worry about charging certainly for these programs, and we hope to build enough goodwill that organizations will, broadly accept that. So or accept this going forward. So that's the intention right now. And that's part of the reason why we've seen such a huge surge in the number of hospitals signing up. I think taking the economic consideration off the table is not only the right thing, but it's making it easy for them. One of the things that's really interesting, money aside, is a large health system has been looking at GetWell Loop for surgical cases for orthopedics and cardiac surgery and a bunch of things for, let's call it maybe a year in their, their typical RFP process as systems think about, buying technology. And then the moment that we made these COVID-19 care plans available, the decision was made and they moved on a dime, literally in a half an hour phone call. And the reflection they had back to us was, it was hard for us to identify the population where we desperately needed to have something engaging them at home. And of course, the COVID-19 epidemic crystallizes that. But I think that's good. I think this is will be, I think, when we do this in 2 years, Stefano, and look back, I do think we'll have a fundamental shift on the delivery of healthcare. And we will think, like, how often do we really need to bring in patients for, a 2-week follow-up to be in the office? Probably not most of the time. And like so much of medicine, I think will move, particularly if there's payment parity, will move to a new model. And I'm looking forward, I hope that this is, of all the things that are happening, there's not a heck of a lot of silver lining right now, but I do think we are going to see a transformation in the way that technology is used to deliver care as a result of this.
Let me ask a couple of maybe quick questions. HIPAA compliance for these platforms.
Yeah, of course.
Sorry, just to make it clear, HIPAA compliance, Health Information Portability and something else Act.
Yeah,
I forget. For those that are not in the United States, it's basically patient privacy data laws in the U.S.
Yeah, we have, in order to do business with the health systems that we do, both here in the United States as well as internationally, the cost of doing business is to be compliant with HIPAA and really other data security provisions. What I am heartened by is Medicare waiving those requirements for a lot of technologies. For instance, if I was running a small independent practice, now I can use Zoom or Google Hangouts or any commercially available or widely available video platform to see patients. And even though that is not HIPAA compliant, absolutely the right thing to just get all of that stuff out of the way right now so doctors can be doctors. So, long term, I think we will return to normalcy, but yes, we are HIPAA compliant and have all
That's
of
the question. That's the answer I wanted. Yes, we're HIPAA compliant. A very practical question from Peter Nudie. I don't know if I pronounced that correctly. With possible COVID-19 patients being requested to refrain from hospital visits, how do you initiate contact with these patients if they don't connect with the healthcare system?
Yeah, so provided that health systems, or if we're looking at public health programs, have a roster of patients that has either email address or mobile phone number, you've got a way to get to them, right? And so enrolling them on these platforms is as simple as getting that data into the system and then letting the system do the outreach. I don't know if I'm answering the right question, but it becomes relatively trivial, again, provided that you've got registration data for them.
Yeah, exactly. It works best for systems that have already a sort of a captured patient population to do the outreach. And if you don't already have that and you're sort of relying on people coming into your office to get on the platform, it's a little trickier. But you probably have a database of patients you've seen in the past that you could enroll. Okay, moving on to the next question. This is from Derek Hayden. I'm afraid I misheard. So the platform is instant messaging based and televisits are a separate type of interaction. And Medicare is reimbursing for both types. So let's differentiate between platforms that do text messaging and communicating versus those that are basically video platforms. Or should there be a differentiation? And I'm afraid I may have lost Todd. I can probably answer that one to some degree. So the billing side of it is somewhat agnostic. The platforms are different. This particular one is largely based on text messaging, and I think they may be developing some video capabilities. Here's Todd. He's back. Excellent.
Can you hear me now?
Yes, you're back. Thank you for being here. Thanks for refreshing is what happened. Oh, you're off again. Internet in this area right now is not great. He'll be back in a second. Televisions are HIPAA compliant if they're encrypted, is my understanding. And and several platforms are encrypted, depending on what level of a video platform you have. So Zoom does at UCSF, we have a HIPAA compliant platform, but the baseline Zoom, I'm not sure is. Todd is back. Excellent.
Hey, Stefan, can you hear me?
Yes, I can hear you back.
To answer the question, there's three different technology segments that I would recommend we think about. One is remote patient monitoring, which is systems that are capturing patients' symptoms day over day and trying to escalate and elevate to doctors when there's issues. That is being paid for by Medicare and commercial payers. Secure messaging back and forth between patients and providers is also being paid for by CMS and others. And then lastly, telemedicine video visits, and that is also being paid for. So there are three different technology capabilities, all being reimbursed at different levels, but certainly providers should be taking advantage of all three, I think. So
a lot of physicians very comfortable with relying a great deal on diagnostics relative to hands-on part exam. This is not, the way you guys have positioned yourselves isn't really as a televisit platform. It's more a patient management platform. Would you say that's correct?
Yeah, so the model with Loop is the Loop system is autonomously working up your patients day over day. And if there's an issue, it surfaces it to the clinical team. And one of the interventions that the clinical team may do is either call the patient at home or initiate a video visit with the patient. And so we are sort of a triage system that helps providers understand when is it the right time to establish a visit, face-to-face or telephonic visit with the patient.
Right. And to answer that, to the way we use the Loop is we see the patient in the clinic, we do surgery, and before and after surgery, they go into Loop, and the Loop prepares them for surgery for a month before and tracks them for 6 weeks after. The visits that we do in person are not changed by that. We would like to move to a point where even ourselves, we're not deploying as fully, because we could use Health Loop to determine which patients really don't need to come back at all, because frankly, they've been great. They're, you can sort of see that happens. A lot of the patients we see back, we don't necessarily, well, they come in and they're doing great, and it's a wonderful discussion, but they probably would have done just as well without coming to see us. But how do you triage it so you only see the ones you really need to see? A platform like this can be quite helpful.
Yep.
Let's see. I wanted to ask a question here. Yeah. What's the intersection between agencies and public health providers, and how does that impact a platform like this?
I'm sorry, can you repeat the question?
What's the intersection between agencies and public health providers?
Yeah. So what we're seeing is states and municipalities trying to figure out how to be a frontline agent to help health systems triage and support their communities. The agencies are really all about setting the rules of the road, or in this case, clearing rules out of the road and providing sort of medical supply, logistical support, et cetera, for the things that FEMA can do. What has been interesting, and this is, I will say, working in the public health sector is new for me, but seeing health systems partnering with public health agencies to treat members of the community.
I didn't realize we went over. I was having so much fun talking to you. We're actually past our time. So I'm going to call this session then and turn it back over to Shauna. And thank you for your participation. Thank you for staying with us on the technological challenges of video, but it's been really exciting. No, wait a minute. I've been told different. Hold on a second. Okay.
It's 1340 is when it comes on 1340.
Oh no, I was right. No, sorry. So I apologize. I'm just trying to figure out exactly. I'm getting it right. So we're going to the next one at 1440. I apologize. We still have time and we have more questions, so I'm going to get to them. I don't think we really have too many more questions to go, though. One thing I was thinking about, I think Jamie Caluet is online, and we can do some really cool stuff with technology. We can try it out here. I'm going to put Jamie on the spot and bring him on. He can't tell me one way or the other. So I'm going to ask him, invite him on screen, and see if he's willing to join us and tell us a little bit about his experience with your platform. he may join us in a second. In the meantime, HIPAA compliance we talked about, the hands-on part exam we talked about. RPM requires a contract between the patient and the provider. Has that changed with the COVID epidemic? That's from Michael Oberlander.
Yeah, so with RPM, what has been required, it's actually a question I don't know the specific answer to, but it has required patient consent. And part of the reason of patient consent is that there has been a co-payment, a self-pay component to receiving RPM services. One of the ways that we've tackled this is to capture consent through the software onboarding process to allow patients to consent to this. I would presume that patient consent will still be required. I would think it would be certainly in a category of things that, given all the other requirements that CMS has waived to kind of unleash technology right now, if they haven't waived consent requirements around RPM, they probably would if people asked them to, because I think they're just trying to get rid of every single possible barrier. And I think it's we lobbied quite a bit when some of these rules got the CPTs got the CPT is a billing code for those that aren't in the United States, got approved for payment to doctors. We lobbied pretty hard that things like remote patient monitoring and secure messaging should not be subjected to co-pays, similar to like wellness visits aren't being subjected. Part of the oddity there is that, particularly even with some of these smaller transactional things like secure messaging, it's a $7 fee and a patient's going to get $1.20, of a copay. It's a little bit bizarre. And so it's a great question. I don't know if there's been any changes to the regulation specific to consents there, but it's probably something CMS ought to look into if they haven't already.
So, Todd, let's just say, by the way, I'm doing terrible coffee in my hands, shouldn't do that. I'm a small group, maybe 20 docs. What recommendations would you have in terms of deploying technology like this, and how much work is going to be, how difficult is it going to be? What's your experience onboarding?
I guess what I would recommend, and with the full disclosure that I've been spending the last 2.5, 3 weeks with large health systems trying to figure out enterprise community strategies. So I haven't really spent time down in the weeds. I think if I was running like 10 to 20 person specialty group, particularly where we were deferring surgeries, I would enroll every one of my patients into a remote patient monitoring experience that opens up secure communication for two reasons. One is to provide them access to us, right, as their providers, because while we may be deferring surgery, they're still in pain, right? Like they still have issues, and we can support them and keep them warm and keep them close to us. It gives us a way to continue to make some revenue, although it's going to pale in comparison to revenue from our surgeries, but at least it's something. And I would guess that now, until coronavirus is really, incredible, if it isn't already incredibly active in your community, some providers have the time now to lean in and do this, right, and get it up and running, and it's a pretty good time to do so. In terms of onboarding, it varies. I think prior to the coronavirus stuff, we were at about a 60-day window from agreeing to work together to launching first patients. Again, the biggest component in that time frame is alignment of clinical protocol and care plans, and ensuring that what gets sent to patients through these digital platforms truly mirrors your clinical practice. And the reason why we've got 3 to 5 day cycles to launch systems on the coronavirus programs is they're just accepting our content as is. And so that's really the factor in terms of launching these programs that can be the difference between a week and a month of lifetime to get started.
Question from Europe from Dr. Professor Tobias Winkler in Berlin. Maybe I missed it, but are there plans to go to Europe? And if so, what are the strategies for dealing with data protection here and reimbursement? Yeah,
so we are in the UK already. Data protection, the tools need to be GDPR compliant for one. There's sort of specific hosting and regulatory matters. So typically, although some regions are combined, we're standing up our cloud-based servers in different regions. So we have a Middle East server, an Australian server, UK server, Canada, et cetera. So there's segmentation of data. In terms of reimbursement, in specific countries, I don't know. I would say up until 2 weeks ago or 3 weeks ago, the countries that were most inclined to work with us were those that had capitated systems. So whenever doctors win through having higher quality, lower cost episodes of care, there's a genuine interest in empowering patients and partnering patients to reduce costs. And so that has traditionally been the driver. I don't even know yet. I haven't gotten my head wrapped around international use for our COVID care plans, but I'm sure we'll start to see demand.
Got it. I'm going to bring into the conversation Dr. Caluette. He's
Hey.
I'm going to bring him up. He's joining us. I'm going to get us all on the same screen. I'm going to try to get us all on the same screen, but I think are you here, Jamie?
I can hear you. Are you able to hear me?
We are. Hey,
yes.
Dr. C.
Hey, good to see you guys.
So I saw you out there listening in. So I thought maybe because you've had experience onboarding this particular platform, and what if somebody's watching and trying to think about whether or not this is the kind of thing he wants to do, what thoughts would you share with them about how to deploy it?
Sure. So we have been a huge fan of Todd's since inception. I don't know how many years we've been working together now, Todd, but it's probably at least 5, I would think. And
5 or 6.
Yeah, so we got involved very early with this. I will tell you that our patients love it. It has been tremendously successful in our practice. I'm an arthroplasty surgeon, and so we use it very effectively for both of our preoperative protocol and then following the patients. We also use it to do all of our outcome tracking, so our HOOS and KOOS scores and all of these things. We use through what used to be called Health Loop and is now GetWell Loop.
So it's interesting because I just want to keep addressing this question that keeps coming up. Will patients adopt these technologies? And your experience as mine is that patients love it. They feel like I'm the one personally reaching out to them, which is great. And I feel connected. And now with the COVID, we've been using the platform also to reach out to patients who are midstream. They're in the middle of a recovery path and have lots of questions, and they can't come in, and we can track them and work with them using the platform, which has been great because they've lots of questions that come through and we can address them. We looked it up. We published this. We had an 1.5-hour delay turnaround time average and getting people their questions answered, as opposed to a much longer turnaround when they left messages on our phone system. So has that been a similar experience?
Yes, we actually have a full-time employee just for GetWell Loop in our office because we use it across all of the different areas in our office: sports medicine, trauma, arthroplasty. And so we have a full-time equivalent whose entire job now is to be online with patients every day through GetWell Loop.
And I would presume that also, how do you justify that cost? I mean, where do you see the return investment from that deployment?
We have seen, we've actually done the analytics on that, and we have seen the return on investment because the patients are so happy with it that they give us very positive reviews. And these reviews go to either Google or Health Grades or the others. And that scale of reviews helps to push your overall rating up. And that in turn increases the likelihood that people who are shopping for a hip or a knee replacement, for example, when they look online and they see that you have a very high number of reviews, you're more likely to get patients from outside of your community coming to you. My personal experience is that I'll have patients coming and driving for several hours because of what they read on the reviews, and those reviews are being pushed through the GetWell network.
So in terms of COVID-19, how have you deployed the technology in the context of managing patients with COVID right now? if you've done that.
We did, and we reached out to GetWell very early to try to work with them in terms of a protocol for COVID. And so we've been using it all along for this challenge.
Excellent. And with that, this time I am correctly ending on time. And I apologize, but thank you for that intervention, Jamie, to give us experience, someone who's actually used it. We look forward to hearing from you tomorrow about the impact that COVID has had on your practice in Los Angeles. To some folks, this idea of physicians working in an environment where we're rated may seem a little bit odd. It may not ring true in maybe in European countries or other places, but I have to say it's probably coming your direction. It's definitely been a progression. And with respect to using these technologies for COVID, of course, they're very, very helpful. And at the same time, once COVID is passed, we'll be able to leverage them to the benefit of our patients in continuum. So with that, I want to close out this session on patient engagement platforms. We're joined by Todd Johnson from GetWell Network, and as a cameo appearance, could get you on screen from Jamie Caluet from Los Angeles. Thank you, everybody, and we'll see you at the next session.
Thank you.
Stefano.
Thank you.
Bye-bye.